Okay, so we are at the last section for today. I'm Emanuela Taioli. I'm at Mount Sinai, and I'm moderating this section. It's called "We Cure Early Lung Cancer." Can we cure early lung cancer? So we start with Bruce, who is here, yes, from Milliman, and his presentation is defining cancer cure.
I have some disclosures there. So we're talking about cure, and I thought it might be fun to have a different context of cure. And you think of what's the sausages and preserving sausages, keeping meat from going bad, and here's some examples of cure. And it's this case is salt cure. Using salt to keep meat from going bad, and this is of course a very small scale, sort of boutique kind of approach, and maybe like where we are with lung cancer screening is not quite at a grand scale. And moving on, there's other kinds of cure, and oddly enough, smoke is used to cure sausages also. Here's some examples of that, and again on a small scale. So, of course, we think of smoke as the opposite of a cure for lung cancer, but one of the themes that we're in, the kind of accomplishments that we've had, that Claudia and David have had over 30 years, we're on the verge of moving beyond a small scale, and here's what that looks like: the early stage of a large-scale cure for sausage. So how it starts. I did stop at a grocery store and brought a prop, but I forgot to bring it. So I want, this is a slide from a publication on some of the from 2019, 2020 on screen versus non-screen and survival. And this is actually from Taiwan, but there's lots of examples of this in the literature. And there's a concept of an approximate cure is when the survival curve, the cause-specific survival plateaus or asymptotes, and that's I think a traditional epidemiological approach to what is a cure. I'm not sure that's perhaps the best way of presenting a cure, but in this case, the bottom line is non-screened and the top is screened. And of course, with the Kaplan-Meier curve, in any trial, you're going to have an asymptote because that's the nature of the step function or the step curve. But so that's the traditional approach. There's different approach. This is typical survival. What I've plotted here is future lifetime of the U.S. population. Let's see, I think I took females based on 2020 mortality curve that is used for the U.S. Social Security system. And the expected future lifetime, obviously decreases over time and continues to decrease after age 100. So this is perhaps thought of as a population or a goal. And if we can get people with lung cancer to get back on this curve, that's a different concept of cure. Of course, this curve reflects all of the different causes of mortality. There's, people riding bicycles and people with cancer and people with heart attacks and everything else in this curve. And when I superimpose on this, I shrunk this down just to ages 62 to 72, and the starburst in blue on the bottom is the expected future lifetime of someone with lung cancer of non-screen detected lung cancer. So that person has a expected lifetime of just a couple of years. And if we can get a different concept of curve is to, if in 1 or 2 years we can get that person back up to the whole picture, then that works. That works well. That's a different concept of cure. Finally, I have, a different lesson from actuarial science. And I've mentioned in the past that actuaries have had some methodological tricks up their sleeve for a long time. Like actuaries were using Kaplan-Meier approach about 100 years before Kaplan and Meyer's paper. And Oli Meitenen challenged me on that, and then he conceded I was right. So this is a different example where life insurance companies will underwrite people before they sell them a policy. It's a standard practice. So if the life insurer, if someone is dying of cancer or has bad heart disease, they're either not going to sell them a policy or charge them a lot. So the life insurers prefer to start with people who don't have any bad conditions, and they'll do what's called underwriting to make sure the person doesn't have any of the obvious conditions of heart disease and lung disease, et cetera. But that wears off. Life insurer sells insurance policies to someone who's age 40. Within a few years, that healthy status deteriorates because that's what happens. People don't stay healthy forever. But what's really interesting is that it turns out some people do stay healthier for a real long time, and other people don't. And it turns out in the life insurance industry, people who are super healthy or just have all the right kind of characteristics never deteriorate to the general population level. So my point in this is almost the opposite of the cure. That is that people are different, people with conditions are different, and we have to be really careful of thinking about that asymptote as being the cure, because that's going to be different for different people. And sure, it's going to look like there's an asymptote when you have clinical trials but when you stratify people and separate them into their characteristics, there really are differences. So that perhaps challenges the idea of saying, yes, we've cured someone. And certainly with conditions like people who have smoking related conditions, the burden of that perhaps never gets fully cured. So just some thoughts there on some of the nuances. Turn it back to Emanuela.
Thank you, Bruce. Any comment? Or we go to the next presentation is David Yankelevitz. Why focus on cure?
Yeah. So I just make a quick comment on what Bruce said. I think the asymptote of the survival rate is a commonly used measure of cure. But I think what Bruce was driving at, and it's something that I agree with, is that asymptote, once it reaches that asymptote, the people then should have an equivalent survival. They shouldn't be dying more rapidly than people to show that you've really made a cure. It should, in essence, parallel a similar population that never had lung cancer. And then those two should be lining up. The rate of death from other causes should be lining up. I think that's what Bruce was saying. They shouldn't be dying more rapidly, that they're now dying at the same rate of a population that never had lung cancer once they've reached that asymptote. And so I agree with that, but that second part is a lot harder to get. So we're good that way. So, but in general, I think the idea of that asymptote is a pretty good start for what we should be thinking about in a way of comparing programs, et cetera, et cetera. Why focus on cure? That's the topic of my talk. And I just want to start with this just some conceptual things and why I think cure is such a big deal. You know, we all understand these issues of what clinical trials look at. And Nelson looked at this, NLST looked at this, and you know that I have some differences of opinions about clinical trials, et cetera, and their importance versus the approach that we took. But here's what I think is really of great interest. Mortality reduction, the primary endpoint in clinical trials, number of deaths over the number of individuals screened. And that's reported in deaths, typically deaths per 100,000 life years. That's the basic metric that's being reported when people talk about mortality reduction. And clearly that was the critical endpoint that allowed screening to get accepted all over the world. Nobody questions that. Case fatality rate, which is primarily what I-ELCAP has focused on, is number of deaths divided by the number of individuals screened. Sorry, the number of deaths divided by the number of individuals with lung cancer. So, you know, deaths per, so we had 20 lung cancers, 30% died, that kind of thing. We talk about deaths per the number of lung cancers. And conversely, we talk about the cure rate. Cure rate is 1 minus the fatality rate. It's the complement. So that's the cure rate in essence, the number that don't die. Now, typically case fatality rate people talk about can't be used because it doesn't account for screening biases. So Claudia and I heard that for 20 years, 30 years. Having people explain to me what lead time bias is, or Claudia had her PhD in mathematical statistics, and people would come up to her and try to explain to her that there's this concept of lead time bias and things like that. But I'm sort of kidding. But these are the two main things. There's mortality reduction, which no question was the primary endpoint that in essence changed the world. And then there's fatality reduction, which in all essence, people said it's the problem with it is overdiagnosis, et cetera. But that's the two endpoints. And now, I just want to ask you, which is the more relevant clinical parameter? What do you want to tell patients? And I give you this hypothetical clinical trial of screening versus no screening to just think about what's really the critical issue that a person interested in screening needs to understand. So let's think of a trial that has a limited number of rounds of screening and long-term follow-up after screening has finished, and we're doing long-term follow-up, like we've seen in many clinical trials. Let's assume that the cancers found under screening are cured 100% of the time. So that the screen-detected cancers, 100% cure, and while you're in the process of being screened, there are 0 interim cancers. So screening does great. And if we have that situation, let's assume that we keep following after screening. If we wait long enough, the mortality reduction of that trial compared to the no screened arm versus no screened arm, the mortality reduction will start to go down. Instead of being 100%, it starts to go down. And you could get a 20% mortality reduction, even though you're curing 100% of the screen-detected cancers, because the trial has continued. The screening arm, we keep counting the cancers in the screening arm because we're not screening anymore, but we still call them the screening arm. So you can easily see, and you see that in clinical trials, including, for example, the NLST. As time goes on, that 20% has gone down to 16%. If we wait longer, it will continue to go down. Now I ask you, what information is relevant to the person interested in screening? You have this clinical trial where you're curing 100% of the people that are staying in screening, and you have this mortality reduction of deaths per 100,000 life years, 20% mortality reduction. If you were to talk to a person about screening, what would you want to tell them? What would they be interested in? That if you stay in the screening program, we're going to cure you 100% of the time, or to tell them we have clinical trial information that shows there's a 20% mortality reduction? What are they more interested in? To me, the answer is obvious. What's the critical clinical information? Now, to me, it's but it's also obvious to others. And this is where I say it gets really interesting. The NLST came out with their result, 20% mortality reduction. You know, fantastic result. As I say, it really changed the landscape of screening. But what happened after that? Take, for example, the American College of Chest Physicians and the American Society of Clinical Oncology. They took that 20% mortality reduction, which was deaths per 100,000 life years, and said 4 out of 5 people who are going to die of lung cancer. Notice deaths per lung cancer. That's the language of fatality reduction. That's not mortality language. It's fatality language. Screening prevents 1 in 5 deaths from lung cancer. So they talked about the 20% mortality reduction, and they said that's a 20% fatality reduction. It's a huge mistake. You can't just convert one to the other. And everybody should really, who's interested in lung cancer screening, really needs to understand that. This is an absolute conceptual error, that they convert it, and they do it very explicitly. They say, here's the explanation from the lead author of that article. 1 out of 5 individuals that were destined to die from lung cancer, deaths from lung cancer, fatality reduction. Which means that 4 out of 5 lung cancers snuck through. That's why they're converting the 20% mortality reduction into a 20% fatality reduction. Remember, I said from screening, you could have cured 100% of them and still have only a 20% mortality reduction. It doesn't mean anything's wrong with the clinical trial. The clinical trial and the use of mortality reduction, perfectly reasonable. So there's 2 points here. One, they made the error in converting mortality reduction to fatality reduction. But the second, a little bit more subtle point, is they understood that this is what patients need to hear. There was the recognition that the critical information you need to convey to patients is fatality or cure, fatality reduction or cure rate. So they understood that conceptually, that that's the information a person needs to hear. They just made a serious error in saying, okay, let's just say mortality reduction is the same as fatality reduction. It's a really interesting point. And as I said, and here's another one. This was from the family practice physicians, and why they were always saying, we shouldn't be screening. It's exactly the same thing. As screening and early treatment delays death for only 20% destined to die from lung cancer. 80% of screened people with fatal lung cancer will die. That's wrong. That's completely wrong. This society, by the way, didn't endorse screening until this year, last year. Very serious error. And I've heard this forever, that how I-ELCAP reports a 60 to 80%, and that's, how can that be? NLST only showed a 20% mortality reduction. You guys are running around saying 80% cure rates and things like that. There's nothing inherently inconsistent with a high cure rate, 60, 80%, and whatever, higher and having a 20% mortality reduction in a clinical trial. Those are not inconsistent numbers. They're different measures and they're not interchangeable. You can't convert one into the other. And so I say, when we think about talking to patients and telling them and getting them interested in screening, how would it affect the balance of risks and benefits if instead of saying 4 out of 5 times you're going to die, instead saying 4 out of 5 times we're going to cure you? Or letting the doctors in particular who don't understand this and are really confused by this, doctors need to know you're not going to die 80% of the time. You're probably going to be cured 80% of the time. It's a very important, that's why I say, and you see that these organizations really get it. They understand conceptually they should be presenting cure rates and fatality reduction, but they made the error in that simple conversion.
Comments? Very complicated to explain all this to a patient. It's not an easy. Okay. Next, talk Dr. Alifano, 20 years cure rate.
Okay, thanks. My presentation will be a presentation of a real life in a completely different setting, the setting of surgery. And Dr. Infante invited me and asked me to present our retrospective experience on a long-term survival of resectable lung cancer. No conflict of interest relating to this presentation. So the main question of this session, can we cure early lung cancer? And the question for me, which are 20-year cure rates? In a clinical setting, few studies assessed the long-term survival beyond 10 years of resectable lung cancer. And I found in the literature some studies, and I show here some of these studies. The first study showed in a cohort study of in a surgical setting of approximately 100 of patients, showed a survival at 15 years around 20%, and with no more details. Sorry. This is another study from Norway, a more larger surgical series evaluating survival at 15 years. And which is interesting, in my opinion, in this paper, that is that authors provided some other elements. Firstly, they showed in the upper curve the expected survival, the survival of a random sample of population matched by age, sex, and year of birth. And in the upper part of the figures, the observed survival after surgery. And in the bottom part of the figure, the relative survival. In other words, survival, expected survival, relative survival defined as the observed survival divided by the expected survival. And an indirect information can be drawn from this display is that most of a cancer death occurred in the first 5 to 7 years and thereafter the shape of the curve suggests a similar risk as compared to the standard population. So the question for me, which is the 20-year cure rate in a surgical series? And so I recently published with my colleagues a paper on results at 20 years of a single center, high volume center of surgical patients, all operated on 20 years ago. So in the pre-PET scan era, pre-targeted therapies era in case of relapse, pre-immunotherapy, pre-anti-angiogenic treatments. And at the time, there was almost no thoracoscopic surgery, no ERAS programs. But it was a real life, it is a real life surgical court with all the stages included, and even all the treatments included in the surgical setting, and even approximately 20% of surgical cases were post-induction. The original court study was a study on the occurrence of post-operative pneumonia, and we collected prospectively in a specified case records form a lot of data about patients' characteristics with a special interest on the nutritional parameters. And this course study was later employed for the assessment of prognostic factors at tumor level. Some examples, the prognostic impact at 5 and 7 years of embols or adenocarcinoma subtypes, but also to study the prognostic impact of a patient's-related factor. This is an example showing how the lung cancer paradox, in other words, high overweight and obesity are protective against in the setting of an operated lung cancer as compared to normal weight and underweight. And also in the evaluation of a patient-related factor, we had a special interest on the systemic inflammation, which is a concurrent cause of the occurrence of many cancers, including lung cancer. And we assessed the long-term impact of systemic inflammation by measure of a C-reactive protein, as our approach is tumor and host factors interact through the tumoral immune microenvironment, which was studied in this paper, where we checked the interaction between these three aspects of the lung cancer pathophysiology. And to answer the question, which is the impact of both host and the tumor factors on the long-term outcome of patients with the resectable lung cancer? So some slides to show rapidly the clinical feature and pathological features of patients. And we assessed the morphomics, nutritional status, and the laboratory. We also performed the laboratory assessment of nutritional status. We recorded the details on surgical procedure, pathologic, and two pathologists performed a reassessment of all the cases and the reattribution of the pathologic stage after relecture. So the question, can we achieve a 20-year cure rate? The answer is yes. As you can see, median survival was 41 months, and figure of 5, 10, 15, and 20 years were 43, 25, 12, and 6%. But the question, the one in this kind of evaluation, the immortality bias is extremely important. So how which was the methodology employed to be sure of the long-term outcome of patients? So we excluded foreign patients. We performed the interrogation of the National Statistic Institute database. We performed the interrogation of municipality of birth of patients. We performed the interrogation of electronic registers of the hospital, but finally we considered alive only patients with the direct proof of life. In other words, if we do not, we consider alive patients with no proof of death, the figures were different, and where we had at 12 years, 11% of alive patients. So the shape of curves is similar, but the results at the end is quite different. And the possibility, as evoked in the precedent topics, of considered alive patients who are effectively dead is possible. So this methodology allowed to avoid this bias. Which are prognostic factors? Female patients did better. In this, at that time, female patients were the minority of the patients, and the significance was close. Importantly, age was an important prognostic factor. All patients which were 80 years old at the time of surgery were dead 20 years later. But there was a significant difference in survival between the different class age. The type of resection, lobectomy and bilobectomy did better than pneumonectomy, but which is important is that also among patients undergoing pneumonectomy, we have some very long-term survivors. With respect to pathological factors, the stage of disease influenced the outcome, and something which is interesting, particularly interesting for you, is the survival curve in stage 1 disease. Differences were also observed according to the histologic subtype in adenocarcinoma. And which is for me at least as important, that different patients-related factor, chronic bronchitis, preoperative BMI, preoperative C-reactive protein level, preoperative weight variation also influenced the long-term outcome. And this was confirmed at multivariable analysis. And to comment these results, briefly would show a recent study based on the EPITOR database, the database of the French Thoracic Society and Cardiovascular Surgery, which contains more than 60,000 patients. And we constructed a sex-specific nomogram to assess the probability of long-term survival, 5 years. And thanks to these sex-specific nomograms and scores, we can distinguish the probability in 5 different groups of patients, the probability of survival in a remarkable, satisfactory manner, and which is important that the same difference in survival can be observed inside each pathologic stage, further suggesting that the outcome is influenced not only by stage, but also by large amount of patient's characteristics. So, can we cure resectable lung cancer? Yes, of course. Can we cure early lung cancer? Yes, even a bit better, especially now, 20 years later. And which factors determine survival at 20 years? Both tumor and host factors, and both should be taken into account. Thank you very much.
Thank you. Very interesting. Any questions or comments?
I have a comment.
Yes.
So, as you know, our group has always been quite interested in long-term survival. And, you know, I-ELCAP just published and Claudia will present her data, but we looked in the literature to see if there was any long-term papers. And yours was the only one that we found with 20-year survival. You were the only one. So, in a sense, it prevented us from saying we're the only ones that ever published 20-year. But we had to reference you, I think. But then we were able to say ours was in the screening context. But I think it's really great, the idea of being able to show 20-year long-term and really start to talk about cure rates and things like that with some degree of confidence.
Thank you so much.
Okay, last presentation is Claudia Henschke, and she'll present updates on cure in I-ELCAP.
Well, mine will be very short. Yes, we can cure it. And I like your idea. So those were individuals who had been diagnosed 20 years ago, right? Or longer. So that must have been with chest x-ray. And is the staging the old staging? So how was the staging done at that time also? But what you want to do now is move forward with that same model and see how it changes in the last 10 years and so on. Very interesting. So our model was always to do direct comparisons with CT and chest x-ray, or CT and blood tests as they develop, a direct comparison of the diagnostic rates. And then we can look at the long-term cure rates, the Kaplan-Meier survival curves out long enough. And we always said, if you really believe in overdiagnosis, well, you could randomize them at that point to treatment or no treatment. And that would prove the point pretty quickly. But and we needed to accumulate a large number of individuals. And so we reported on the cure rate at 10 years. Now, in the New England Journal, we only had 2 or 3 people that had actually been gone out to 10 years follow-up, but that was the cure rate for all cases, whether they came back for annual repeat, whether they, regardless of the stage, some of them chose not to be treated even. And we showed that if they were in clinical stage 1 and got resection, they did much better. These were all staging or detection with CT scans. And now that we have more individuals, we updated the cure rates, and if you're diagnosed under annual screening, which includes interim diagnoses, then the cure rate has remained the same over 20 years, even though, let's say, half of the, a little bit more than half of the individuals have had 10 years of follow-up. Not everybody has had 20-year cure rate, 20-year follow-up. And if we know what it is, if you don't have screening, it's between 5 and 15%. So that's the long-term follow-up of our study. And the initial comments were lead time bias, length bias, overdiagnosis bias. The only positive one of the comments on the New England Journal was from Ugo Pastorino. He said, this is good and this looks promising. So thank you, Ugo.
Thank you, Claudia. Any comments? Or we're basically done for the day, right? That's our, yes.
Okay, so now we have a catch-up talk. Dr. J, which she's closing the session, I guess. No comments from the audience, questions? Oh, I can tell you one thing. We just got a comment from the audience. I was sent a comment from Zoom from somebody listening in. The comment was, "Thanks for this. Screening saved my life!" Exclamation point. No question, but I'm disturbed by the negative comments surrounding screening. Very thoughtful audience member.
So, and the other important thing that I didn't say is that the consensus is now that it takes 8 to 10 years of follow-up to really understand where that curve levels off. And in multiple studies in multiple countries, that has been shown with at least 4 or 5 papers.